It's time for the 3-question warm-up for Heme 6. Let's get going. What is the rate-limiting enzyme of beta oxidation of fatty acids? So the answer is carnitine acyltransferase 1. Next question. What cofactors are required for the function of pyruvate dehydrogenase? And then what other enzyme requires the same cofactors? So first one that we need to know here is that mnemonic that we gave you. It's that tender, loving care for no one, which stands for thymine pyrophosphate, lipoic acid, coenzyme A, FAD, and NAD. And then what other enzymes require the same cofactors? That's going to be alpha ketoglutarate dehydrogenase. Next question. What is the result of a glycolytic enzyme deficiency? And what is the result of a deficiency in pyruvate? So first, what about that glycolytic enzyme deficiency? Well, your red blood cells are dependent on glycolysis for energy. So red blood cell hemolysis is the result there. And then what is the result of a deficiency in pyruvate dehydrogenase? Well, primarily with this one, you get neurologic defects. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're continuing our discussion of anemias. And remember, we're dividing up the causes of anemia based on the size of the red cells. So we discussed microcytic anemia, where the red cells are smaller than normal, in a previous video. And in this video, we'll discuss macrocytic anemia, where the red cells are larger than normal, and also normocytic anemia, where the red cells are normal in size. There just aren't enough of them. So let's start with macrocytic anemia, where the MCV is high and the red cells are too large. We can divide macrocytic anemias into megaloblastic anemia, which is due to impaired DNA synthesis, and non-megaloblastic anemia. Now, it's not always easy to distinguish between them because there can be some overlap. The main causes of megaloblastic anemia are B12 deficiency and folate deficiency. Now, megaloblastic anemia is due to impaired DNA synthesis. And because you have trouble making DNA, it takes a long time for the nucleus of the red cell precursor to mature, and the cytoplasm expands in the process and the red cells just get larger and larger. Now, one important clue that you're dealing with megaloblastic anemia is the presence of hypersegmented neutrophils, meaning the nucleus of the neutrophil has more than 6 lobes. So if they show you a smear with big red cells and then off in the corner is this lonely little neutrophil, you might tend to ignore it. But if you notice that the nucleus has more lobes than normal, think about megaloblastic anemia. And folate and B12 deficiency can also sometimes cause glossitis, or inflammation of the tongue. B12 deficiency can cause neurologic defects like peripheral neuropathy and also dementia. Folate deficiency won't cause those. That's a very important distinguishing point. Both B12 and folate deficiency will cause elevated homocysteine, but with folate deficiency, methylmalonic acid will be normal. With B12 deficiency, methylmalonic acid will be increased. That's another good clue. But fundamentally, how do you determine which is which? So if you have a patient with megaloblastic anemia, you're going to suspect either folate or B12 deficiency. How do you tell them apart? In practice, you're just going to check a B12 or folate level. The causes of folate deficiency are things like malnutrition, especially in alcoholics who are living on booze and aren't eating very well. Also malabsorption, medications that interfere with folic acid metabolism like methotrexate or trimethoprim. Or if you have a high folate requirement like hemolytic anemia or pregnancy, that might lead to folate deficiency. Now, what kinds of things cause B12 deficiency? Well, it's a lot of the same things. Malnutrition, again, especially in strict vegans. They have to take B12 supplements. Alcoholism, malabsorption, including pernicious anemia, Crohn's disease, and also the fish tapeworm Diphyllobothrium latum can cause B12 deficiency. Then one other quick point is that if you have someone with megaloblastic anemia, you don't want to treat with folic acid empirically, although that's actually the most common vitamin deficiency in the U.S. It's tempting just to start some cheap, safe, over-the-counter folate pills. But the problem is that empiric treatment with folic acid, it may correct the anemia, but if there's also B12 deficiency, that folate isn't going to treat the B12 deficiency, and you can still get all those neurological problems from the underlying B12 deficiency. Earlier in the course, we also discussed one type of megaloblastic anemia that is not correctable by giving B12 or folate. Remember what that was? Orotic aciduria. We talked about orotic aciduria as a disease related to the deficiency of the enzyme UMP synthase, which is involved in pyrimidine synthesis, where you get orotic acid in the urine and megaloblastic anemia, but you do not see hyperammonemia. Hope that sounds familiar. If not, you should probably go back and review that. And then what about macrocytic anemia that's not classified as megaloblastic? So most of the time when you see macrocytosis, it's going to be megaloblastic anemia, but sometimes it's not. So what are the kinds of things that cause macrocytic anemia where you don't have those hypersegmented neutrophils like you do with B12 or folic acid deficiency? Well, you can see that with liver disease, or with alcoholism due to bone marrow suppression. So here's where we get some overlap. Alcoholism can lead to B12 or folate deficiency and megaloblastic anemia, but alcoholism can also be a cause of macrocytic anemia by itself without the megaloblastic component. So make note of that. And then certain drugs like 5-fluorouracil, which is an anti-cancer drug, and also zidovudine and hydroxyurea. Those are all potential causes of macrocytic anemia that is not megaloblastic anemia. So we've talked about red cells that are too small. We've talked about red cells that are too big. So what about anemia where the cells are just right? Well, that's called normocytic anemia. You can split normocytic anemia into two major groups, hemolytic anemias and non-hemolytic anemias. We're going to talk about the hemolytic anemias in the next video. But for now, let's just talk about the non-hemolytic anemias. And that differential is pretty short. There's anemia of chronic disease, which we mentioned earlier with the microcytic anemias, because anemia of chronic disease commonly causes normocytic anemia, but then it could eventually cause microcytic anemia. So let's add just a little bit more detail about anemia of chronic disease. So when you have inflammation, you have a lot of inflammatory mediators like IL-6. They're going to cause the liver to make this hormone called hepcidin. And that inhibits something called ferroportin in the macrophages so that iron gets trapped in the macrophages. So you have plenty of iron, but it's trapped and you can't get it to the red cell precursors in the bone marrow. So again, you see low serum iron, low TIBC, and normal or high ferritin. Moving on then to aplastic anemia. Aplastic anemia is where the marrow just gives up and quits making cells altogether. So you might see pancytopenia, or failure of the marrow to make any cell lines. So you can have anemia, leukopenia, and thrombocytopenia. No red cells, no white cells, no platelets. And you definitely need to know the histology of aplastic anemia. You have hypocellular bone marrow with fatty infiltration. So if on your test you see a bone marrow and it's filled with adipocytes, you know you're dealing with aplastic anemia. The symptoms are pretty much what you'd expect. The patient has anemia, so that's going to cause fatigue, malaise, and pallor. They have thrombocytopenia, so they can have purpura and petechiae and some bleeding. And then with leukopenia, you can see infections. So you can see how these different cell lines are going to cause slightly different clinical presentations. Then, what causes aplastic anemia? Well, the main thing to know is that radiation causes aplastic anemia. So cancer patients that receive radiotherapy can get aplastic anemia. Exposure to benzene can cause it. Certain drugs can cause it also, things like chloramphenicol, and cancer drugs like the alkylating agents and antimetabolites. Viral infections like parvovirus B19, Epstein-Barr virus, and HIV can all be associated with aplastic anemia, particularly in sickle cell patients. They're just particularly sensitive to some of these viruses. Fanconi anemia, which is different from the kidney disease called Fanconi syndrome. This is Fanconi anemia, which is caused by an inherited defect of DNA repair. And then also idiopathic aplastic anemia. So we don't know what causes it, it just happens. And that can follow acute hepatitis. And then finally, what's the treatment of aplastic anemia? Treatment's not too important for step one, but you need to stop the offending agent if there is one. Sometimes we use immunosuppressants, transfusions as needed, and you can give one of the granulocyte macrophage colony stimulating factors like GCSF or GM-CSF to help stimulate the bone marrow. And then a bone marrow transplant would be an option if the patient isn't responding to anything else. And then the last cause of normocytic non-hemolytic anemia is renal failure. So the kidneys normally make erythropoietin, but if the kidneys are shut down, they're not going to make erythropoietin. So renal failure patients often require regular erythropoietin injections. So again, if you can kind of lump these diagnoses together into the appropriate categories, remember the big picture, remember the softball stuff like classic presentations, you should do just fine with anemia. For instance, if the question stem says anemia and then the bone marrow is filled with adipocytes, that's going to be aplastic anemia. If the question stem says that there's anemia with hypersegmented neutrophils and neurologic symptoms, it's B12 deficiency. So you just have to have certain key points tagged in your mind to each of these specific causes of anemia. All right, now it's time for your end of session quiz. First question, what are the causes of aplastic anemia? So radiation was the big one. Then also think about benzene, and there are several drugs that can do it, such as chloramphenicol and cancer drugs. Remember, chemo commonly causes anemia and leukopenia. Viruses like Epstein-Barr virus and parvo B19 can cause it, and so can Fanconi anemia. Next, a patient's diagnosed with a macrocytic megaloblastic anemia. What's the danger of giving folate alone? Well, the problem is that if the patient has anemia due to both folate and B12 deficiency, starting folate alone may correct the anemia without correcting the B12 deficiency. Then the patient might end up getting a peripheral neuropathy. So we give folate with B12 to these patients. And then the last question says, what is the cause of anemia given each of the following statements? Now, this is a review of anemias that we covered in this video and the previous video. So microcytic anemia with swallowing difficulty and glossitis is classic for Plummer-Vinson syndrome, which is associated with iron deficiency anemia. Microcytic anemia with greater than 3.5% hemoglobin A2 is beta thalassemia minor. Macrocytic anemia plus hypersegmented neutrophils is megaloblastic anemia, which is most commonly due to B12 or folate deficiency. Megaloblastic anemia that's not correctable by B12 or folate supplements, you're going to think about orotic aciduria. Megaloblastic anemia plus peripheral neuropathy, think about B12 deficiency. Microcytic anemia with basophilic stippling is most commonly lead poisoning. Microcytic anemia that's reversible with B6 supplements is sideroblastic anemia, which we said has several different causes. An HIV-positive patient with macrocytic anemia, remember, zidovudine could do this. So this patient may be on zidovudine, causing a macrocytic anemia. And normocytic anemia with elevated creatinine is chronic kidney disease, resulting in low erythropoietin levels. That's it for this video. I'll see you next time.
Good evening, students, and thank you for tuning in to Ask Dr. Acula with me, Dr. Acula. Tonight's episode is on a topic that is close to my heart, if I had one: blood drugs. The first question comes from Jill from Ohio. What is the characteristic appearance of red blood cells in a patient with iron deficiency anemia from chronic blood loss? It's a great one, Jill. The answer is hypochromic and microcytic. Now, our next question came off our new message board from user First Year Sucks. What are the clinical uses of erythropoietin? Another good one. The answer is anemia caused by end-stage renal disease, anemia caused by HIV infection, and anemia in some cancer patients. It doesn't work, however, on anemia caused by the undead who feed upon the living. Thank you again for joining me. And remember, your exams don't have to suck. Unless, of course, you're me.